short 20-minute video on a retrograde case like we've just been talking about, and this is similar to the case that we'll be doing today. Good morning, I'm Dr. John Herzenberg, and we're going to be demonstrating today a retrograde femoral lengthening using a precise magnetic intramedullary nail. This patient has a 5-degree valgus deformity of the knee and a 2-centimeter limb length discrepancy. The etiology of the discrepancy is Legg-Calvé-Perthes disease. Our goal is to correct the valgus deformity and to also lengthen. The valgus deformity has an apex at the level of the knee, so that's why we're doing a distal correction. I've marked out the level of the knee and the line of the femur. The nail we've selected today is a 215 millimeter length nail, and we have to measure the level of the osteotomy. There's a minimum distance that we must preserve in the female end of the nail. So the way that's calculated is by accounting for 3 centimeters for the distal male tip of the nail that protrudes, plus the amount that we're lengthening, which is here 2 centimeters, plus an additional 5 centimeters for security. Total 10 centimeters from the tip. If we were to do the osteotomy higher, closer to the tip of the nail, we'd have instability. So the farther away from the tip of the nail we are, the more stable we are. So the minimum distance is 10. We'll probably go back about 11 or 12 centimeters and do the osteotomy just above the knee here. In addition, all patients undergoing a femoral lengthening need to have a fascia lata release. The fascia lata is a very tight structure and resists lengthening. We've tested her popliteal angle, which measures 35 degrees, which is satisfactory. But if she was having a bigger lengthening than 2 centimeters, I might elect to do a recession of the biceps femoris and a release of the semitendinosus. We're going to start by putting on a tourniquet for just a few minutes for the fascia lata resection. Lift it up there. I can feel the fascia lata. It's a very tight structure, and we're going to make an incision just at the superior pole of the patella, about 2 centimeters in length. The glistening white tissue is the fascia lata. At the level of the superior pole, I'm going to make a small incision in it, down to the muscle. Next, I use a Metzenbaum scissor to go above the fascia to the midline anteriorly, and below the fascia also to the midline. Then I'll open the scissor slightly and incise to the midline. That's the release of the fascia lata anteriorly. Now posteriorly, I'm going to put my scissor inside the fascia lata until I hit the intramuscular septum, outside just to dissect it, and then release it to the intramuscular septum. It's a very thick structure. If I lift up the vastus lateralis, I'm down to the level of the intramuscular septum and down to the level of the femur. I'm going to leave this incision open because I may want to use it for putting in a locking screw, putting in a pin for the X-fix. Next, we're going to obtain a starting point for the nail. I've bent the knee about 45 degrees and checked on both the AP and lateral views. And this wire is what I call try before you buy. Before we make an incision, we want to make sure that this is the right level. So I've determined based on the x-rays that this is the perfect trajectory. So now I can take the wire out and we'll mark it and make about a 2 centimeter incision for inserting the nail. This is going right through the patella tendon. So it's the so-called patella tendon splitting approach. Now I'm looking at the fat pad, but we're not going to do anything to the fat pad other than use it as an entry point. In this case, the level for the osteotomy, I want to be above the knee joint, above the suprapatellar pouch. And if I just take advantage of this incision for the fascia lata, I can sneak in here and do the osteotomy. making one entrance and 3 exits. You have to be a little bit careful with this drill bit. I'm using a 3.8. If you bend it and within the bone, it can break. So I'm being very careful to withdraw it before I redirect it. I've done 3 entrances and about 4 or 5 exits. We've perforated the canal. That's going to serve a couple of purposes. Number one, it tells me where the osteotomy is, and number two, it's going to vent the canal so when we do our reaming, we won't have increased intramedullary pressure. Now, if I was doing a straight lengthening, I could start the reaming right away. Because we're doing a deformity correction, I want to take a few minutes to put on an external fixator. The external fixator is going to allow me to do the correction so that the reamer will pass where the nail is going to be. So I have to actually do the osteotomy before we ream. We can get the starting hole in the skin, but for the starting hole in the distal femur, we have to first do the osteotomy. The next step is to put an X-fix on for control. It'll control 2 things. Number one, the rotation of the femur, and number 2, the angulation for our valgus correction. With the C-arm, I'll position the open finger hole ring of this clamp to guide where the X-fix pin is going to be. It has to be outside the path of the nail, so I have to be very careful to make sure it's not going to interfere with the nail insertion. This wire was put in under fluoroscopic control, so it's outside of the path of the nail. I'm going to ream over that with a 4.8 millimeter drill bit and then put in a 6 millimeter pin. We'll then put one more pin in proximally above the level of where the nail will reach. One more. All right, save it. Take it out, including the sleeve. Cross table. Okay. Save it. This pin is put in with the knee inflection so that I can get the knee into the proper position for nailing. If I put this pin in extension, it may tether the extensor mechanism and not allow me to flex the knee. This is the 215 millimeter mark. I'm going to come above this with this pin so that we'll stay outside the passage of the nail. Picture? This is the try before you buy wire. I want to make sure that our incision will be at the right place. I'm going to rely on the equator technique for putting this pin. I'm not going to put a wire in first. Picture? That was a good feeling of going through the canal. Now I'm going to the second cortex. So I've got a soft tissue sleeve to protect it. I have my assistant pull out the drill and the sleeve, but I'll leave the soft tissue sleeve there intact. And I'll put the pin in, and we're protecting the soft tissues that way. When I go to extract this pin at the end of the case, because this is a temporary external fixator, we'll reinsert the soft tissue sleeve protector to protect the soft tissue on the way out as well. These 2 pins are parallel to each other, and if they remain parallel at the end of the case, we know we haven't induced any rotational deformity. With this device, I can check the parallelity of the pins, and I can see that we are within a few degrees of each other. So now we're ready to cut the bone, do our correction. I'm feeling the back of the bone, and I'm going to do the posterior cortex first. Picture? Picture? If I get some comminution, it's okay, and it's complete. So I'm translating about 5 millimeters and then angulating into varus. I'm pushing my hands apart to give a little bit of varus. We'll check it in a minute with the Bovie cord. Picture the knee. That looks pretty good. It's going through the medial tibial spine. Let's say that's normal alignment. Go up to the hip, please. Okay, that looks pretty good. Save that. And go down to the ankle. Okay, looks good. Now go to the knee. Okay, save it. We have to make sure that we're still reduced in the sagittal plane, so let's go to a lateral x-ray. That's the osteotomy in the sagittal plane. I want to see what happens when I flex the knee to put the nail in, because sometimes the osteotomy will bend. Looks good. Let's look at the knee now. So even though we're bending the knee, we have a good maintenance of the alignment on the sagittal plane. So to get the actual starting point, we'll use a 3/32 diamond pin followed by an 8mm ACL reamer. So I'm looking at a lateral x-ray, and I put my diamond pin in through the incision that we have in the patella tendon, and I'm looking at the C-arm. We're just at the top of Blumensatz's line. I'm going to drop down a tiny bit, picture, and get my starting point right about there. I'm the judge on the AP if I'm aiming too medial or lateral. What I'm aiming for is that medial corner. Picture, and that's about where I want to hit it. Okay, let's go to a lateral now, and we're going to use a bent nail here today, or we could use a straight nail. Picture, a straight nail might work. Ream out the posterior cortex a little bit. Let's go to an AP. That's good. So I know my nail is going to pass, even though we have the obligate translation. Let's go to a lateral. Okay, looks pretty good. All right, so we'll take that. Let's have the reamer. Picture. I save that. So we're reaming by 0.5 millimeter increments, and we're going to go up to make sure, maybe a couple centimeters beyond to make sure we're totally in the confines of the nail. Stop. So I think we'll go to a hand plus a thumb. That's a distance away we want to do it. Save the reamings. So we've completed our reaming. We've reamed the canal a little bit beyond where we thought the nail was going to end, just to be on the safe side. I'm cautious about reaming too much anteriorly in the proximal femur because I don't want to create a fracture or a stress riser. Next, we'll put our nail in. It looks like a straight nail is going to work here nicely because we pretty much got a straight path. I have a couple of rituals that I do, and one of them is before I put the nail in, I take some betadine and I prep the skin. I don't want to drag any skin organisms. And we'll also change our outer gloves, put on clean gloves for this part of the case. So I've assembled the nail onto the insertion jig. This is the insertion jig with the little extension for the distal femoral nail. I can test the jig to make sure that our 4mm drill bit will fit through, which it does. Now you notice I keep the sheath in place because I want to keep this nail completely sterile until we put it in. This is not a cannulated nail, so I'm going to take out the guide wire. So the nail inserts easily. I don't have to really bang it. I can just slide it up. I can lock it on the medial side because I have a fixator here, but what I did, since the traditional way of locking a nail is laterally, I cut this X-fix pin to allow me to put the jig on the lateral side. So we'll put the locking screws in laterally. I'm going to put the distal locking screws in. It looks like I could kind of sneak this incision down that I use for the fascia lata, and not only do the osteotomy through it, but I can also put in one of these locking screws through it. There's a very tight tolerance between this drill bit and the hole in the nail, so I'm not going to drill through it. I'm just going to drill down to it and then tap it through. Picture. So I'm down to it, and now I'm going to disengage the drill. Picture. And now we got through it by tapping. It's a little bit easier than drilling sometimes. And I can read the length of the screw off of this. It's calibrated. So looking like a 55. The screws used for these are pegs. They're not fully threaded. Only the near end is threaded. So when we put it in, we can literally push it through until it engages, and then just give it a couple of turns to engage the neocortex. Now let's see if we can't use that same incision for the distal screw. Picture. So I've got the two distal interlocks placed. We no longer need the insertion jig. Got a little lucky today with one incision where we released the fascia lata, did the osteotomy, and put in two locking screws. That's not typical. Show us the knee. So it's going through the medial tibial spines. We're going to put in a blocking screw. And that screw will help prevent the piece from going back into valgus. Now all we have left to do is to put in our locking screws. Picture. Okay. Good. So we've locked the nail distal, proximal. We put in a blocking screw, two locking screws. We got two locking screws for the same incision we did the osteotomy plus the fascia lata. Next we're going to do is remove the bar and locate the magnet and test the nail. We'll go out 2 millimeters just to make sure it's really working, and then if it's okay, we'll go back 1.5 millimeters. Now I'll leave the X-Fix pins in for a little bit, just in case for some reason the nail wasn't working. We had to take it out and redo it. So that's the magnet. What we want to be looking at really is not the magnet, but the little top hat that's above it. So we see the 3 planetary gears just below my wire, and just above the wire is this sort of upside down bowler hat. We're going to position the ERC so that the black line on the ERC lines up with the purple line that we drew for the magnet. This ERC is set so there's a little homunculus here showing a skeleton of the person. It's got the head, the hands, and the feet. We line it up the same way. This assumes that the box is programmed for retrograde because we have a retrograde nail. So it's important that you do that, otherwise you'll be compressing the device instead of distracting it. So we're ready to go for 2 millimeters. We just tested the nail. This is before distraction, after distraction. And we see this little upside down bowler hat, the top hat. And if I look just above there, there's no space. And here now I have a big space, and you see there's a washer in there. It's called an oblique washer. So we know that we've distracted. We know the nail is working. We want to compress the nail back again because we believe in the principles of Ilazarov. The machine is set at retrograde. If we continue like this, we'll be lengthening more. To compress the nail, we simply reverse the device and leave it set for retrograde. Or we could reprogram the box for antegrade, but it's easier just to turn this upside down. And we programmed it to go 1 millimeter, so let's go. Now, why are we only shortening 1 millimeter if we lengthen 2? When we did this acute correction, the osteotomy is under compression, it's under tension. And so an actual millimeter of distraction is not really a millimeter of distraction until you undo the compression. There are some physicians who don't go back at all. They just leave it distracted. I like to follow Ilazarov's principles and undo the distraction that I did to test the nail. But in this case, we'll just undo it by 1 millimeter instead of 2. We can see that there's been a little bit of compression and only went back 1 millimeter, so it didn't change too much. And now we're going to finish up the operation by doing a couple of things. We have to take off the fixator, and I want to put in one more blocking screw just to be on the safe side. I'm concerned that as we lengthen, the proximal piece will tilt into varus. down to the bone. And I don't usually use drill sleeves for this part of the procedure, but I am cognizant not to go too medial off of the bone because that's where arteries live. Picture. Take it out. Let's go back to an AP. That's a good shot. See if you can see the two blocking screws. All right, now let's take out the X-fix. And the last thing we have to do is to just wash the knee out a little bit. We're going to do it right through the same incisions we already have. I'm using this same incision one more time to put a cannula in the knee just for washing it out. We'll take the irrigation inflow. Okay. Let's turn the water on. If there are any bits of bone in there, we kind of like to wash them out. Just to review the incisions, this is where we put the nail in. This is where we had an X-fix pin, another X-fix pin, two locking screws, fascia lata, corticotomy, and two locking screws, blocking screw, blocking screw. Full range of motion. She needs 2 centimeters of lengthening. We'll hopefully achieve that within about 2 months. Good morning, I'm Dr. John Herzenberg. Yeah, sorry I can't go. Good morning, I'm Dr. John. Take it out. Dichotomy and two locking screws, blocking screw, blocking screw. Full range of motion. She needs 2 centimeters of lengthening. We'll hopefully achieve that within about 2 months. Yeah. Well, during the lengthening, the tendency is sometimes to go into varus. Next picture. Yeah. I guess I felt that the nail was against the cortex laterally, but maybe not completely. Yeah, so I see your point is you would have put it on right through the same incisions we already have. Dichotomy and two locking screws, blocking screw. Yeah. Yeah. Okay.